hopefully it is a review for you. The first 3 lectures actually of this block are review material. You have been exposed to this in the past. The reason I do this review is, 1, maybe it's been a while and you don't recall because you've learned so much more information since you learned it. Or 2, maybe you didn't quite understand it fully. And if you still don't understand the basic, the foundational stuff before we jump into the more complex topics, you're going to be at a disadvantage. So hopefully I can bring us all up to the same playing field before we start throwing the important information at you, okay? That being said, yes, you will be tested on the first 3 lectures of this block, okay? I got to come up with 50 questions, and if I get rid of half of my lecture material, I'm going to struggle to get 50 questions. So you do need to know the material on the first 3 lectures of this, okay? So when we talk about the cardiovascular system, the discussion really has to be more than just about the heart. Because yes, the heart is the pump, but how does it move blood through the body? It has the arteries, it has the veins, it has the capillaries, right? That's the portion of the vascular and cardiovascular is the plumbing that brings that blood to the different systems in your body. Now the cardiovascular system is one of the most regulated systems there are because it interacts with every other system in the body, right? Do your intestines interact with your big toe? Well, yeah, maybe the nutritional absorption does, right? But does it have a direct impact on your big toe? And the answer is no. Does the cardiovascular system have an impact on your big toe? It does. If you don't believe it does, talk to any poorly controlled diabetic who has their big toe fall off, right? It's very important. But not only is there interaction of the blood, the cardiovascular system with blood going to the different organ systems, but those organ systems have a way to communicate back up to the cardiovascular system to regulate the blood flow to them. Hey, I'm not getting enough blood here. I need more. I'm going to release this compound that then is going to deliver more blood to the body, or to that portion of the body, to that organ system, whatever. So it's tightly regulated internally, but it's also tightly regulated from all these other systems, all these other organ systems, in order to make sure that supply is meeting the demand for that oxygen, the demand for those nutrients necessary for it to do what it needs to, okay? So when we look at the cardiovascular system, we got to kind of understand how is this thing packaged, how is this thing situated in order to deliver the functional response that we need and want. Well, we know the heart is in the center of the chest, maybe deviated just a little over to the left, right? But it's not just sitting there, forwards and backwards. It's actually kind of tilted, rotated to the left, and then back. So because of that rotation and that kind of backward trajectory, what ends up happening is the most anterior structure of the heart is actually the right ventricle. It's not the left and the right ventricle side by side like we normally depict in graphics of the anatomy, okay? And that's important to know because if I suffer blunt chest trauma, what's the structure most likely going to be affected by that? It's going to be the right ventricle, right? Because that's the most anterior structure. Now the most posterior structure, because of that backwards tilt, is the left atria, okay? Which makes it, when we talk about the imaging, it's one of the reasons evaluating the left atria is very difficult with a transthoracic echo. And if we need to get a good detailed view of the left atria, we may have to go and do the more invasive transesophageal echo, okay? So there's a reason and there's challenges that develop based on this rotation and kind of backward tilt of the heart. Now, of course, the other things that kind of surround it, kind of maintain and protect the heart. So you've got the lungs on either side, right? You've got the sternum in front. You have your esophagus, your trachea in the back, in addition to like the vena cava and the aorta as well. So you can kind of understand how the heart, the pump of the cardiovascular system is packaged and how it interacts with stuff in the chest. So let's start by looking at the anatomy, and let's kind of work our way outwards, inwards, okay? So the most outward structure of the cardiovascular system, or of the heart, is the pericardium. And the pericardium is made up of two layers, a visceral and a parietal pericardium, and they do different functions. So the parietal is the outermost layer. It's thick, it's fibrous, and the visceral is the innermost, and kind of creates a frictionless environment for the heart to sit in. Now, I was always confused, how is the pericardium only 2 layers, but really it's more like 4 layers, right? And you can kind of see in the graphic here, kind of imagine you have a deflated balloon, and you put your fist in the middle. It's going to kind of envelop around, and that's what's happening with the heart. So really it's only 2 layers, but it looks like it's actually 4 layers when you look at it, okay? There is a little bit of fluid in this space. And that's important because that fluid creates that frictionless environment for the heart to work. Do you have any physics majors, engineers, or anything like that in here? What does friction do to work? Decreases it, right? So if I didn't have the pericardium and now I'm in this friction-full environment, I'm going to lose work for the heart or the pump because I'm having to counteract that friction force, okay? So that's one of the reasons having that fluid is important, and why the pericardium is important, creating that environment. Now the other 3 reasons that the pericardium is important is, 1, it adheres to other structures to kind of stabilize the heart. This way you don't have a free pendulum sitting there in your chest. Imagine you're running and your heart's just swinging back and forth. What's going to happen to that? Well, I imagine it's going to be one hitting other structures, right? But it also is going to start to kind of pinch off the outflow and the inflow tubes. And imagine what that's going to do to its function, its pumping function. If I kink and now I'm not getting blood out of the heart, okay? So it attaches to other structures, maintains position of the heart in the chest. Now the other thing is it prevents that extreme dilation. As I'm running, I'm increasing that blood return from my extremities, right? What happens if I have so much blood coming back that my heart just continues to stretch? I can't squeeze it out. So the pericardium kind of gives this counter resistance so that it can maintain a more physiologic function or environment to function. And then the final thing is it's a barrier of infection. How many times a year do you have an upper respiratory infection? Probably far too many. If you have kids, it's probably every week, right? What happens if those viruses that affect your lungs and cause a respiratory infection, what if they had the ability to go directly and impact the heart? And when we talk about pericardial diseases, you'll see a lot of the viruses that can cause respiratory stuff can cause and impact the heart itself. So what if I had no barrier to protect from the lung and the infections of the lungs? I'd be more prone to things like pericarditis, more things like myocarditis, and what are the impacts and stuff from those types of infections and them affecting the heart. Let's continue to work in. So we talked about the pericardium. Now the heart layer, there's 3 heart layers, 3 layers of the heart. And you can see actually the one layer, the outermost layer, is already something we've kind of accounted for. So the epicardium is actually the visceral layer of the pericardium. Okay? So you kind of got some redundancy there. But that's the outermost layer of the heart. Then you have your myocardium. This is your muscle layer. And then you have the endocardium, which is your innermost layer. But to make things more difficult, it's not, okay, we have 3 layers of the heart, right? But we have sublayers within those layers. So the endocardium actually is comprised of really 2 main things. It has the contractile portion, which is the muscles themselves, that actually provides the function of the heart. But then you have the non-contractile portions, which are going to be kind of like, think of it as the support and the regulatory components that control the function of the heart. So now you're talking about your conduction pathway that you're learning about in EKG class, right? That's in the endocardium. The blood vessels that provide blood to the muscle so that it continues to function, right? And then some of the other more important structures. Looking at the endocardium, this is the innermost layer. This serves as a barrier to prevent blood from within the chambers of the heart coming in direct contact with the myocardium. So that way you're not depleting all of your oxygen in your blood going to the myocardium even before it leaves the heart. Okay? It's going to be regulating how much oxygen is getting to the myocardium itself. You don't have an easy path through the chamber of the heart into the myocardium itself. Now you're learning about the conduction system in the in EKG class, right? But this is important to know that yes, the action potential and the coordination of the squeeze of the heart, it starts with the SA node in a normal heart, but the path that it takes to get from point A to point B in order to get that contraction of the ventricle, it has to go through some intermediate pathways to get there. So going from the SA node to the AV node, you have these internodal pathways that bring that action potential from the SA node down to the AV node. But this is all on the right side of the heart, right? How do I get the left side to participate as well? Well, particularly the left atrium. How do I get it to participate? Well, I need this little Bachmann's bundle to go over to the left atrium. And when you talk about your P wave in your EKG class, remember the first part of the P wave is your right atrial depolarization, right? And the last part of it is the left atrial depolarization. There's a delay of that depolarization from right to left because I have to get that signal over to the left from that SA node, which is within the right atrium itself. But let's follow that action potential down to the AV node. You're going to get your little pause, right? That's your PR interval. And then it's going to conduct down the His-Purkinje system. Now, what's interesting is this area here is insulated. And it's not until you get down to the apex of the heart do you start to get a contraction of the heart, of the ventricle. And why is it that that insulation of the bundles is important? Think about a tube of toothpaste that's half full. If I squeeze in the middle, what's going to happen? Toothpaste goes down to the base and also out, right? I'm losing volume by it going downwards, right? But if I insulate that part and I wait to depolarize the ventricle until I'm down at the base, what happens? I now get a coordinated up and out type of squeeze. I'm making the pump more efficient. I'm not wasting effort. Okay? So it's important that that happens. Now, that coordination within the conduction system is internal to the heart. But we talked about how these other organ systems kind of interact and control the function of the heart. So how does this happen? Well, one way is actually using the Bainbridge reflex. And this reflex is not a conscious thing, it's a subconscious thing, where the atria detect that they're having all this extra volume coming back to them. They start to stretch out. That then triggers the reflex to kick in, where the atria will then communicate to the central nervous system to then come back and say, you need to squeeze harder and faster. So what's going to happen is I'm going to increase my heart rate, and I'm going to increase the strength of that contraction in order to get rid of all that extra blood that's coming back to the heart. Okay? This is very important when we are exercising and we're increasing that venous return back to the right side of the heart. Another way that your heart's kind of regulated and the function of the heart is regulated is actually with just your respiratory cycle, your normal respiratory cycle. When I inhale, I create a negative intrathoracic environment. So now what happens is I have more pressure in my extremities than I do in my chest. So flow of fluids goes from a high pressure to low pressure environment, right? So just me taking a deep breath in is going to increase that venous return, which then can then be counteracted when I then exhale. And now I create a positive pressure, thoracic pressure, and now that kind of decreases my venous return, okay? So kind of think of somebody who has a tachypnic or a very fast breathing rate. How would that affect venous return? You normally don't think of it affecting the heart and its function, right? But it can. So it's more than just blowing off too much CO2. It's more than just having excessive amounts of oxygen. It actually does carry some cardiovascular effects from it. And then the final way, or another way, is the autonomic nervous system, which there's two parts to the autonomic nervous system, but really it kind of boils down to this system can regulate not only how fast the heart is beating, but it can also impact how fast that action potential propagates through the heart and how strong the contraction is going to be in that cardiac cycle. When we look at the sympathetic nervous system, this is your fight or flight response, right? If I am in a state where the sympathetic nervous system is in overdrive, what am I going to expect is going to happen? Well, I'm going to have the SA node, so it synapses on the SA node, which is going to increase my heart rate. So instead of my resting heart rate of 60 beats per minute, the sympathetic nervous system is going to stimulate the SA node to fire faster so that I can have a faster heart rate. It's also going to interact and synapse on the atrias. And that interaction is important because it's going to speed up how fast it gets from the SA node, that action potential gets from the SA node, down to the AV node. So I increase my conductivity. But then it also makes the atria squeeze harder. So it increases the contractile function as well. The sympathetic nervous system also synapses on the AV node, and that increases the conduction velocity of the action potential through the AV node, and then it does synapse on the ventricles as well, and that will increase the contractility, so how strong your contraction is going to be, and it also increases how fast that action potential propagates through the conductive pathways within the ventricle. So I can get that through faster and get that squeeze faster and get that blood circulating faster. Now, the sympathetic nervous system interacts with those four sites. When we look at the parasympathetic, or the rest and digest portion of the autonomic nervous system, you'll see it actually only interacts with 3 of the 4 sites. It does not synapse and interact with the ventricles, which makes sense because what would the parasympathetic nervous system do to the ventricle? It's going to make you not squeeze as hard. So you can dial up the squeeze, but you can't dial down the squeeze necessarily. You're going to go basically to normal or baseline function. But it does synapse on the SA node, and it will slow down your heart rate. It does synapse on the atria, and it's going to slow down that conduction velocity in the atria, and it's going to interact with the AV node and affect the conduction velocity through the AV node. And then, oh, by the way, I forgot, the AV node, or sorry, the atria also has a decreased contractility, so you get less of a squeeze with the atria, with the parasympathetic nervous system. When we talk about action potentials, it's also important to note that there is a difference between the action potential propagation within the myocardium when you compare that to the conductive pathways, or the pacemaker cells. And you can see with this action potential, I'm not expecting you to be able to label phase 0, 4, 3, 1, 2, 3. I'm not going to expect you to do that. But what I want you to know is that when we talk about the depolarizing event of the muscle, we are dependent on 3 ions. You need sodium, you need calcium, and you need potassium. So imagine what would happen at that level if you have a distortion of those electrolytes. What would that do to the muscle? Well, let's compare that to the action potential of the pacemaker cells, or the conductive pathways of the heart. It's only dependent on calcium and potassium. Yes, there's a little bit of sodium in there, but the sodium doesn't really have much of an effect on the action potential generation and propagation through the conductive pathway. So calcium and potassium are your 2 ions that are important. Well, why is that important to know that there is a difference between the action potentials of the cardiac muscle and the action potentials of the conductive pathway? Well, let's say if I wanted to develop a drug that slowed the heart rate down, would I want to be using a sodium channel medication? The answer is no, right? It doesn't impact the action potential generation and propagation within the conductive pathway. Sodium doesn't. But does it make sense that maybe I might want to alter calcium channels? And that's what we did when we developed the non-dihydropyridine calcium channel blockers, which, if you recall, I don't know, have you learned them in pharm yet? Okay. That has more of an impact on heart rate control when compared to the dihydropyridine calcium channel blockers, right? So that's why it's important to know that there's a difference in that action potential in the conductive pathway and the action potential in the myocytes themselves. So let's get back to the anatomy. So when we look at cardiac muscle, it is made up of a bunch of muscle fibers that you see here. Well, and those muscle fibers are then made up of a bunch of myofibrils, which then are made up of these little sarcomeres, which is basically a group of interacting myosin and actin filaments. And breaking that down will show you, and understanding what's happening with that interaction with actin and myosin will tell you why we get a muscle contraction with that. But recall that calcium is important not only for the action potential, but it's also important for the actual function of the muscle itself. When the action potential comes in and says depolarize, the muscle fiber is then going to use that calcium channels to then bring calcium in to the muscle fiber itself. And there's actually this little sarcoplasmic reticulum, which is like this web-like structure that kind of goes around all those fibers. And that serves as a good reservoir for calcium. But it'll bring in all this calcium because calcium is needed to bind to your troponin sites here, which then exposes your actin monofilaments so that the myosin head in the sarcomere can then bind to it and then do its little power flex movement that you see here and cause the contraction of the sarcomere, which then leads to a much bigger scale where you see the shortening of that muscle fiber, which then on an even bigger scale means you have a contraction of the ventricle or the atria. And then what does that mean? I'm circulating blood. Okay. So you can kind of see, you can follow what's happening down to the microscopic and even the electron microscopy kind of level to see how that stuff works in order to provide this much bigger function. Questions about that? Well, let's move on and actually start looking at the gross anatomy. So I don't need a microscope necessarily to look and see these structures. Okay, let's follow a deoxygenated red blood cell through the cardiovascular system and see how this works, okay? So deoxygenated blood comes back to the right atrium via three means. Okay, you got your superior vena cava, you have your inferior vena cava, and then the coronary sinuses bringing back all that blood that went to the coronary arteries to provide oxygen to the myocardium. Those will all come back to the right atria, and it will pool, it will collect there. This is typically a passive kind of process. You don't have like a true pulse to your veins, okay? So that's why the venous return can be impacted by exercise and those types of things, because you're using all these other structures, muscles, and those types of things to circulate that blood in the venous system. So that blood is going to go to the right atria, and during diastole, the mitral valve, the tricuspid valve is going to open, and you're going to have blood start flowing from the right atria into the right ventricle. Most of this is passive, meaning there isn't a squeeze involved to get the blood from the right atria to the left atria. Okay? It's a passive process. So that means that I'm reliant then on pressure and pressure differences for this flow to occur. Okay? So if I have a much higher pressure in the ventricle than I do in the atria, I'm not going to get the flow going in the right direction. I've got to have that pressure higher in the atria than in the ventricle to get that flow going down into the ventricle. Now, towards the end of diastole, you then get an active phase where the atria is depolarized via your P wave on your EKG, and I get this squeeze of blood, which basically drastically increases the pressure in the atria. So I'm squeezing every little ounce of blood out of the atria and into the ventricle before systole begins. This is the atrial kick. And about 25% of your ventricular volume comes from the atrial kick. So 75% comes from the passive flow, 25% comes from that atrial kick. Now I've got all that deoxygenated blood in the right ventricle. That right ventricle then receives that impulse or that action potential to start to depolarize, and then it starts to squeeze, and now systole starts. And what happens is, as that ventricle squeezes, it's going to then close the tricuspid valve, and then it's going to open the pulmonic valve. so that I can have flow of blood out of the right ventricle and into the pulmonary artery and into the lungs themselves. This is important because obviously we need to oxygenate our blood before it comes back to the left side of the heart. Now the blood returning to the left atria is oxygenated, and that is what I need to circulate into my systemic system, right? I need to get that oxygen to all these cells and all these organs all throughout the body. So oxygenated blood comes back to the left atria. During diastole, that mitral valve is open, and you get blood flowing from the atria, the left atria into the left ventricle, and this occurs during diastole. Similar to the right side, you're going to have a little atrial kick right before systole starts and right at the end of diastole to try to get as much blood out of the left atria into the left ventricle. Now the left ventricle is going to contain all of that oxygenated blood, and this is the structure that's going to convert preload to your afterload. Okay, so those are some terms you probably know from other classes. We're going to look at these at the end of this lecture in a little more detail. But the ventricles are what converts preload to afterload. Okay, and because the left side of the heart has to deal with much higher pressures than the right side of the heart, that left ventricle will be larger, it will be thicker than the right ventricle is, because it has to be able to generate a much higher pressure to get blood circulating out of the left ventricle and into the aorta and the systemic arterial system. Questions about the chambers? So let's look at the valves and talk about how these work and why they're important. The valves of the heart are the key structures that give you that one directional flow of blood up and out of the heart or through the heart from the atria into the ventricles, okay? Without valvular integrity, this pump is not going to work correctly. And in block 3, we're going to talk about conditions where these valves do not work correctly, okay? So when we look at the atrioventricular valves, so AV valves, these are the two valves that are between the atria and the ventricles, okay? They are open during diastole, and they're closed during systole. When I am listening to heart sounds, that closing is S1. So when the atrioventricular valves close to start systole, that corresponds to my S1 on auscultation, okay? And you're going to see there is a difference between the mitral valve and the tricuspid valve, okay? So tricuspid's on the right side of the heart, mitral valve's on the left side of the heart. Mitral valve is also known as the bicuspid valve. Bi meaning two. There's only 2 leaflets to the mitral valve in a normal person. In a tricuspid valve, tri meaning 3, you're going to have 3 leaflets to it. Okay. So you can kind of just, if you don't know which is left, which is right, you can just look at the number of leaflets of the valve and kind of get a good idea of which one is the left side and which one's the right side. And those things. When we look at the semilunar valves, however, these are the valves, these are your pulmonic valves and your aortic valves. These are the outflows of your ventricles. These are open during systole, and they are closed during diastole. The closing of these valves is your S2, which is the start of diastole. Now you may be wondering, well, why is it that I'm hearing them close, but not really hearing them open? Think about a door that is well lubricated And do you hear it open or do you hear it closed? Closed, right? Same goes with the valves. You're not hearing them opening up, but you're hearing them snap shut. Okay? So that's why you hear the closure of the valves in a normal heart. We are going to talk about heart murmurs, and those are going to be different, where the valve itself is diseased, so you're hearing extra things going on. But in a normal heart, S1 is the closure of your tricuspid mitral valve, and S2 is the closure of your aortic and pulmonic valves. Okay. Both the aortic valve and the pulmonic valve contain 3 leaflets. Okay. So all valves in the heart contain 3 leaflets except for the mitral valve. Okay. So 3 out of 4 have 3 leaflets. That brings us to about 50 minutes. So let's go ahead, take 10 minutes. We'll come back at 1400 and finish up.
This is far right there.
She's filling out the sheet.
Everybody got your credit card done? Go ahead.
Okay, thank you. Try not to knock this over as I walk past.
I was looking for that merch. He got it on his list.
I got this checkbook.
I just like how.
The box office. Military ID.
Better than costume.
What I used to do was like for the blog, I go to the box office, I show 5 packs, and get 5 tickets. You have to because of me. Probably.
So, a family friend of mine, he's serving his mission in Pennsylvania. He sent his dad a sock, and that's it. I love
There's nothing around more
This is what my son said. It's so the same. Yeah.
I'll tell you mine. That's my number 1.
I was registered church and sit like this right next to the bishop. This is pretty funny.
Oh, that's on my list now.
And there were people like
I told her, look at this, and I'm like,
You should have been a PE student yesterday, come with the day. They were like, my husband, anytime he tells Maddie, okay, send my prescription for this. Every day,
Yeah, I'm looking at like I remember looking at it, but like you gotta ask me.
Yeah, I went up. Back to like.
Yeah, I went up to the.
I agree, EKG, I'm like,
Hold on. What there's so much of the market. Can't hold on to it.
kind of buddy in bed. Where is
Where's Dover? And where are those things?
Oh, yeah.
Right.
You should have dropped your prescription, then they would send you a text saying it's ready, and then on your way you just pick it up. That's how it's done. I have to do that. I did it with the phone. I'll show you the message, Tracy.
What they have, I mean, they have.
It must be really backed up. Because I know sometimes my husband does that. Wow, look at you, more apples, more apples a day.
I'd probably say north and south.
Blueberries? It's Tylenol.
that's not fun.
We can both at the same time. Put 1 pound on each of their. Can't go get a anything.
She like, what's the one I said, no, it's
Two and one. So everybody's like, I think that's more Hey, if it's me, dude, just call me.
I think they want no more than like 6 hours.
I'm gonna have to get all my plates here. It's all great. I feel like it's yeah, so it's
Headaches, but not very hard.
Washington rain is more.
So bad. Like now there's like a big chunk of rice.
Yeah, I got it. I see what you mean. Our good friend was the baby guy.
So my vegetable.
And now, They live It just got flatlined in front of like 4 different people there. And clearly the balls were like this.
Sit on a submarine, like if you and I were like bunkmates, you would sleep during the day, and I'd sleep at night. I'd sleep
Alright,
at
that was 10 minutes. Let's get back to our seats and continue. Who are my airborne folks? Okay, what do your risers do? What if I cut one of your risers? Yeah.
That's not what you want.
So your papillary muscles are basically the risers of your valves, of your tricuspid and mitral valves, okay? You'll see there's going to be this little muscle part, the papillary muscle, that then goes into the chordae tendineae, and those attach to the actual leaflets of the tricuspid and the mitral valve. These are such important structures, even though they are so small, because they are the things or the structures that give you that one-way valvular integrity of the mitral and tricuspid valve. Okay. Without these, you're going to have regurgitation. So blood is going to flow in the wrong direction. So blood's going to flow from the ventricle into the atria. So these are such important structures. And what's actually interesting is they're so important that, remember how I told you like the bundle branches are insulated so you don't get squeezing there in the interventricular septum too early? You actually have little offshoots from the bundles that go to the papillary muscles first before you get to that Purkinje system or the base of the heart, because I want those muscles to kind of contract and start giving me that counter resistance on the valve leaflets before that ventricular pressure, the systolic pressure starts to build and shut the valve so that I don't have this excessive billowing backwards of the valve. I need that counter resistance to maintain that integrity, that one directional integrity of these valves. So the papillary muscles are so, so important. And we're going to talk about some pathologies where like I have a bad heart attack that kills my papillary muscles, and now I have acute onset mitral regurgitation. What is that going to do to the heart? Sneak peek leads to death. Okay, so these small structures are so vital and so important to it. So you cannot forget about the papillary muscles. You cannot forget about the chordae tendineae and them attaching to your valve leaflets. Now, another thing about anatomy is Chest x-rays. One of the most common cardiac tests you're going to do in a patient that you're evaluating for cardiac disease. And what's interesting is it looks like it's just this hazy blob right there, center of mass, right? But there's so much information I can get from just simply looking at an AP or a lateral view of the chest. And you can see how the two compare. If I am looking at the right heart border, what structures am I looking at? Well, if I look here, starts with your superior vena cava, comes down into your right atria, and then into your inferior vena cava. So your right heart border has no right ventricle in it. Just right atria, superior, and inferior vena cavas. When I look at the left heart border, look at what it is. Okay, kind of started up here, I got my aortic knob, got my pulmonary artery, I then get my left atrial appendage. I'm not getting the left atria, I'm just kind of getting a little appendage coming out from the left atria. And then I get my left ventricle. So on an AP view, I'm not getting a lot of great view of the right ventricle. And I'm only getting a teeny tiny view of the left ventricle. But let me look at the lateral, because one view is no view in radiology, right? You need those two views. So when I'm looking at the lateral, you can now see that all these structures that I didn't get a great view of, an idea of, now become apparent. So when I'm looking at the anterior surface of the heart, I'm looking at right ventricle into the pulmonic artery. So my anterior border is right ventricle pulmonary artery. My posterior is actually going to be, depending on kind of where you're looking, it could be your left ventricle, left atria, but it also could be that you're actually looking at the curvature of your descending aorta as your posterior wall. So, but imagine what happens if I have right ventricular hypertrophy. So now the right ventricle is larger than normal. What change am I going to see on my x-ray? I'm going to see that anterior space start to get occluded. So if I see that anterior space being a problem, that should make me kind of think, maybe I have RVH. So there's something abnormal to the heart. Something anatomically abnormal to the heart. The other thing about the x-ray is I can actually see the size of the heart. And remember, the heart should be no more than half of your chest width side to side. So here's an example of this patient. And I drew the line for the border of the right to the left side of the heart. Let me move it over. Is that greater than 50%? And the answer is yes. This is cardiomegaly, right? An enlarged heart. We didn't necessarily go in and specifically say which structure of the heart is enlarged. It's just, it's bigger than 50%. It's cardiomegaly. Okay. Now let's start looking at the coronary arteries. We are going to spend a lot of time looking at the coronary arteries in block 2 when we start talking about ischemic heart disease and acute coronary syndromes and stuff like that. But let's address some of the foundational knowledge that you need to be successful in block 2. So the openings of the coronary arteries are called the ostia. And these are tiny openings that are just above the aortic valve. To the point when, with the aortic valves open, very little blood can get into them. When is the aortic valve open? Systole, right? When do arteries normally perfuse? Coronary arteries, yes, diastole. But normally, arteries are being perfused during systole, right? You're getting that active flow. But the coronary arteries are perfused during diastole, and there's two reasons for this. One, I need those aortic valves to be closed, right? So I can get that backwards flow of blood in the aorta and the aortic root in order to perfuse those arteries. And you can kind of see on this one image that I included before the lecture, these are not on your slides, but you can kind of see, here's your opening right here of one of your coronary ostia. And look at how that valve is. And this isn't like a fully open aortic valve, but imagine that being fully open, how that's going to occlude blood flow going to coronary arteries. The other reason it's important for the perfusion of the coronary arteries to occur during diastole is, what is the myocardium doing during systole? It's contracting, it's squeezing, right? If I have an artery that's going through this muscle layer, and that muscle layer is contracting and squeezing, what's that going to do to the artery? This very small, not very strong artery. It's going to collapse it, right? So now, I'm not getting blood flow through. So if I'm reliant on coronary arteries to be perfused during systole, like normal arteries are, I'm not going to get the blood flow I need. So the body is uniquely designed so that that perfusion occurs during diastole, when I'm resting. And now I can get all that oxygen, all those nutrients, and all that blood circulation occurring to meet the demand of the myocardium. But imagine what happens to that blood flow if I have a medical condition where my diastolic pressure is too low. How is that going to affect the blood flow in the coronary arteries? It's going to diminish it. And we're going to learn in block 2, diminished blood flow in the coronary arteries means heart attack, right? So you can imagine how all of this stuff has to be such tightly regulated in order to have a normal functional performance, right? But it's more than just perfusion of blood into the coronary arteries. You don't have one coronary artery that perfuses the entire heart, right? You have the left anterior descending, you have the circumflex artery, you have the right coronary artery, you even have the posterior descending that we're going to talk about in the next slide. But these arteries go to specific regions of the heart. So if you have a blockage or perfusion is affected into one of those arteries, imagine what's going to happen to those structures that are perfused by that artery. Left anterior descending artery, also known as the widowmaker. Why is it known as the widowmaker? Because it perfuses the bulk of your left ventricle. We said left ventricle is vitally important in converting preload to afterload, so getting and maintaining a systemic arterial pressure, right? So if I were to take out, say, 90% of my left ventricle because the LAD is knocked out, what's that going to do? Widowmaker, death, right? It also does perfuse your bundle branches. So if I knock out the LAD, maybe I'm going to see things like left bundle branch blocks, right bundle branch blocks, kind of depending on what side is affected, right? But look at the circumflex artery. Not one that we typically think of as being important, right? It does part of it, it does the lateral part, it does do a portion of the posterior wall, but it's not known as the widowmaker, so maybe it's not that important, right? But let's see, 25% of patients, it perfuses the SA node. So if I am one of those 25% of patients who have the left circumflex that perfuses my SA node, and I have a occlusion of that artery, what's going to happen when that SA node dies? I'm going to start to get arrhythmias, right? That's what EKG is all about, is analyzing and seeing these arrhythmias. But are we starting to see how at an anatomical level, a disruption of the normal leads to all these different types of pathologies, okay? And that's what cardiovascular is like. We also don't really consider the right coronary artery as being that important. We don't have fancy names like Widowmaker assigned to it. But that's only because it's not as common to have right coronary artery occlusions. But if I were to, yes, it does the inferior wall of the left ventricle. Yes, it does the right heart structures, right? But look at these two things. Imagine what happens when you knock out 70% of patients where the SA node is perfused by the right coronary, or the AV node. Let's knock out the AV node. Who wants to have that with their heart? Right? Imagine the arrhythmias that will develop with the AV node gone. Right? So the right coronary is important. You got a question?
Sir, why is it less common than it would be a right coronary artery occlusion?
That's a good question that I don't have a great answer for. It's just normally when we do, like when we look at coronary arteries, like with either catheterizations or with CT chests, it's usually we start to see those calcifications and stuff like that occurring in the left anterior descending, maybe left main regions, okay? I don't have a great reason why the left is more susceptible to the right. I can look that up and let you know on Tuesday. So, but that's a great question. Yeah. Because you think that the same physiologic things like the cholesterol being too high is going to affect both the left and the right coronaries, right? Should be equal. The pressures are about the same, if not the same, right? So let me look and give you an answer to that. You do have a backside of the heart, and have you guys learned about posterior wall MIs yet in EKG? Okay. There's a backside of the heart. There is circulation that has to go to the backside of the heart in order for it to function properly. And you can see this is kind of a codominant kind of region where you have both the left circumflex artery that kind of loops around and starts to perfuse a portion of it, but the right coronary artery does as well. So that's one of the reasons why if you have an inferior wall MI, you need to do a posterior EKG in addition to a right-sided EKG, because is that right coronary artery occlusion affecting the posterior wall as well? Is the left circumflex able to make up that difference in perfusion so that the posterior wall is not dying from that heart attack? All that we just talked about leads to this: a coordinated, functional squeeze to meet the demands of our body. Pretty amazing, right? What's not so amazing is we got to talk about the physiology of what's going on too. And this is where you have to do math, right? Hate math, right? It's pretty simple math. There is some algebraic stuff because you got to solve for x and those kinds of things. But we'll show you what kind of math you need to know for the class and for the test. So the whole purpose and the whole function of the heart is to circulate blood, right? I need a cardiac output, and that's our measure of work, our measure of function, right? So how do I measure my cardiac output? Unfortunately, I can't get great exact measurements without having to do a left heart catheterization where I'm putting monitors directly in the left ventricle or directly inside left atria, those kinds of things, okay? So cardiac output, yes, we can mathematically solve for it, but pretty invasive to actually get the real values of this, okay? So what exactly is cardiac output? The mathematics of it is cardiac output equals your stroke volume times your heart rate. And basically you're going to have this many milliliters or liters per minute. Okay, that's what it's going to break down into. But your stroke volume is made up of a lot of different factors that we'll talk about, but ultimately you can mathematically kind of narrow it down to stroke volume is equal to your end diastolic volume. So how much blood did I have available to squeeze out of the ventricle minus the volume of blood that I had after the squeeze. So now I'm getting a product of how much left the heart with that one squeeze, okay? And then I gotta multiply that by heart rate, so you gotta take your pulse, or you gotta calculate it on your kg if that's what you're gonna use to calculate the pulse. But that will tell you what your cardiac output is, because I've learned with this one squeeze of the heart, I had X milliliters leave. And now let me multiply that by how many beats per minute I have, and then I get my cardiac output. So let's try an example of this. So let's say your end diastolic volume is 120 and your end systolic volume is 50. So 120 minus 50 is 70, right? So my stroke volume is 70 milliliters. Let me multiply that by my heart rate of 70 beats per minute. And let me simplify. And you can see now I'm down to 4,900 milliliters per minute, or 4.9 liters per minute. So that's my cardiac output. So cardiac output equals the stroke volume times heart rate. Stroke volume is equal to the end diastolic volume minus your end systolic volume. So you can get that value of how much is squeezed in that cycle. But like anything in life, it's a little more complex than the math likes to portray, because stroke volume is made up of preload, contractility, and your afterload. Okay? So what are those things, right? I know you've learned about them in Pharm. You may not have quite understood them. But preload is a measurement of either the volume of blood in the ventricle at the end of diastole, so how many milliliters of blood do I have in the ventricle that I can squeeze out, or it's a value of that pressure that's present at the end of diastole. So when we say preload, we could be talking about end diastolic volume or end diastolic pressure, okay? They're synonymous. It's hard to get an exact measurement of this without doing cardiac catheterization and doing a pretty invasive test. And we will have a lecture dedicated to the different types of cardiac tests that we can do. So these terms are not familiar to you. Bear with me. We will go over that in much more detail. Your preload is more than just a value. There's actually a lot of stuff that goes behind it. So to be able to have a volume of blood to squeeze out of the ventricle, I have to have a volume of blood coming back to the heart, right? So preload is affected by your venous pressure and the rate of return, so that venous return. I gotta have that blood coming back to the heart. I also have to have that atrial contraction. Remember, I said about 70% of the volume of blood that's moved during diastole occurs passively, but the atrial contraction does about 25%, right? But imagine a condition where that atria doesn't contract, and now I'm losing 25% of my potential volume there. And you all know of a medical condition that does that. AFib, exactly. So in AFib, I lose that atrial contraction. In AFib, if I already have a diseased heart, what is that going to do to the overall function of the heart? It's going to diminish it, okay? Other things that can impact that preload is the resistance from the valve. So how much effort do I need to exert in order to open those valves? What is the ventricular compliance? So is my ventricle ready to accept it? Will it stretch? Kind of think of it as like a water balloon. Is it going to stretch and accommodate all that blood coming during diastole? Or is it going to be a rigid structure where I can only put a little bit in before that pressure starts to drastically increase? And then heart rate also is a factor. But this is not a heart rate like beats per minute. The heart rate factor of preload is actually how much time do I have in diastole. If I have a heart rate of 180 beats per minute, that diastolic time is very short, right? Most of the time is spent in systole. But let me slow down the heart to 50 beats per minute. Now I'm having a lot more diastolic time, which now allows me to have more time for that ventricle to fill and have that blood coming back to the atrias and going into the ventricles. Okay. So that heart rate is not beats per minute, but just how much time do I have for diastole. Myocardial contractility is how powerful the squeeze is. How powerful are those muscles to squeeze and pump the blood? And we talked about like autonomic nervous system, i.e. sympathetic nervous system, and how it impacts the squeeze. But we also have medications that can also help and cause a much more powerful squeeze, okay? Even probably what most of you drank this morning, right? Just to be able to function. It had an effect on your heart of improving the squeeze, the strength of your squeeze. Okay. If we have medications that can increase the strength of your squeeze, does it make sense that we probably have medications that can also decrease the strength of your squeeze? Yep. Two very common ones that we prescribe, calcium channel blockers and beta blockers, right? Who hasn't heard about those? They decrease the contractility or the strength of the squeeze of your heart. Now the last value is afterload. Again, do I have any engineers here or people who actually absolutely love physics? I'm not one of those people. Laplace law, is that familiar to you? It's on the board or it's on the slide. Very complicated, and you're like, man, all these variables, what the hell? Fortunately, when we talk about cardiovascular and we talk about afterload and its impacts on the cardiovascular system, we can simplify afterload to blood pressure. Okay, so we don't have to really do complex calculations in order to determine what our afterload is. What's the blood pressure? Because ultimately, what your afterload is it's the pressure or the resistance of blood flow out of the heart. So how much pressure does the ventricle have to create in order to open up the aortic valve? How much pressure does that ventricle have to maintain in order to keep blood circulating out? Because the moment that your afterload exceeds the strength of the pressure of the ventricle, you're getting a closing of the aortic valve. Okay? So you've got to be able to have that circulation of blood, you have to have the ventricle creating a higher pressure than that afterload. But imagine if your blood pressure is 110s over whatever, how much pressure do you have to exert? Versus 230 systolics. I have to be able, in order to have that circulating blood, I have to have a higher pressure in the ventricle than what the afterload is. So what ends up happening is the afterload is actually, it has an inverse relationship with your stroke volume. So the higher your afterload, the lower your stroke volume, because I'm having to exert a lot more pressure and effort to circulate blood. The lower my afterload, the less pressure I need to generate in order to circulate blood. So I'm going to increase my stroke volume because more effort is put into circulating versus trying to overcome that pressure. And there's a couple of factors that affect the afterload. So what's the tone of the arteries themselves? Are they in a vasodilatory effect or are they a vasoconstrictor? Think about why we use nitrates when somebody is having a heart attack. We want to dilate and open up those coronary arteries to try to restore perfusion. What's the aortic pressure? And is there evidence of valvular disease? Because if there is valvular disease, either I am having to exert more effort in order to open those valves, so I have to generate a higher afterload in order to, I have to generate a higher pressure in order to overcome that afterload, or do I have like a regurgitation where now I'm having a backwards flow of blood, and now I'm losing pressure in the wrong direction. Okay. Other things that can affect the physiology and function of the heart are things like acidemia, hypoxia, alcohol. So excessive amounts of alcohol is cardiotoxic. So please don't drink more than 2 in a sitting, or else you may be damaging your heart. And then heart rate can also impact that. But going back to the calculations, we talked about cardiac output, and we talked about how it's difficult to exactly measure cardiac output without having to do invasive testing. Is that a practical thing to calculate in all of our patients? Do I need to do a cardiac catheterization on every patient who I am evaluating for cardiac disease? Potentially. The answer is no, right? So we have a different value that we can calculate in order to give us a general idea of how well that heart is functioning, okay? And that's your ejection fraction. This is estimated, okay? And basically the math, the way it works is your ejection fraction is your stroke volume divided by your end diastolic volume. I need a percentage, right? So I need to have some division, numerator, denominator, I can't remember which one goes underneath. But you need, to be able to get a percentage, you need to have that end diastolic volume in this case. So in the example of, if we say our stroke volume is 50 milliliters and our end diastolic is 100, then my EF, 50 divided by 100, is 50%, right? A 50% ejection fraction. So 50% of the blood that was there at the end of diastole was ejected out of the heart during systole. Okay? And what's interesting is normal ejection fraction is anywhere from 55 to 75%. You're not ejecting 100% of your blood every time your heart beats. Okay? So 55 to 75% of that volume of blood leaves the heart every time your heart squeezes. Okay. So how can we calculate, or how can we estimate the ejection fraction? Well, the gold standard is the cardiac catheterization, but this is a pretty invasive test. So do we have a less invasive option? And the answer is yes. The most common way we calculate ejection fraction is with your echocardiogram, your echo. Okay? But there are some other ones. So even just doing a cardiac MRI, I can actually calculate their ejection fraction. Am I ordering cardiac MRIs on every patient that I want to see what their function is? No, because it's going to cost way too much. And you think it's bad waiting 2 months to get your knee MRI done? Imagine if we're ever to do all these MRIs just to kind of calculate EFs. You're going to be waiting a year to get your knee MRI for your torn ACL. So echocardiogram is the most common method we use to calculate the ejection fraction. And then this is just a summarization slide of the different math formulas. So ejection fraction does not equal stroke volume. The ejection fraction is your stroke volume divided by your end diastolic volume. Your stroke volume, if we're going to break it down, is your end diastolic volume minus your end systolic volume. So in reality, your ejection fraction is end diastolic volume minus end systolic volume in parentheses, get that product. Then divide that by your end diastolic volume. Okay, so that's the math behind ejection fraction. Okay. Questions on the math part? So let's finish up with just a couple of additional physiologic points. Okay, so this is a normal cardiac pressure loop. Okay, so we're going to start here, and at this point, this is your mitral valve opening. Your mitral valve opening now means you have the flow of blood from your atria, if it's mitral valve, your left atria to your left ventricle, right? So that flow of blood means that I'm going to have an increase in my volume. So I'm moving on my x-axis over here towards the right. But I'm also, as that volume is moving into that ventricle, the pressure inside of that ventricle is going to slowly rise. And you can see that pressure is your y-axis, and that is slowly increasing. Until you get to a point where the pressure in the ventricle exceeds the pressure of the atria. And when you get to that point, you're going to get a closure of your mitral valve. And that closure of your mitral valve is your S1 on auscultation, which means it's going to start your systole. Okay? Now, the problem is that pressure to close the mitral valve was a lot less than it is to open the aortic valve. So now I need to generate a much higher pressure in order to open that aortic valve. Well, I'm squeezing, that aortic valve is still closed, so my volume is not changing at all. And you can see that on the x-axis, we're not moving either way, right? That volume remains constant until I get to a point in my pressure on the y-axis where now I have exceeded that afterload. I've exceeded that pressure on the opposite side of the aortic valve. And now I get an opening of the aortic valve. Now I'm getting a flow of blood out of the left ventricle. And then you start to see that now I start to move to the left on the x-axis because I'm losing volume because that volume is circulating out of the heart. Okay? I still am generating a higher pressure. You can see even though I'm losing volume, I'm still generating higher pressure because my ventricle is still squeezing closer and closer and closer. I'm maintaining that pressure to keep that aortic valve open. But I'm going to get to a point where now I've lost too much volume that even though I'm still squeezing, I'm not going to be able to maintain that pressure to keep that aortic valve open indefinitely. And what happens then is I'm still losing a little bit of volume, but now my pressure starts to drop to the point where now that pressure on the aorta side of the aortic valve now exceeds the pressure of the ventricle, and now I get a closure of the aortic valve. That starts diastole, and you see the mitral valve is still closed because the ventricle pressure, even though it wasn't high enough to keep the aortic valve open, it's still high enough to keep that mitral valve closed. So now I then have an isometric relaxation. That pressure is rapidly dropping, but the volume does not change because all of the valves are closed at this phase, this early phase of diastole. And then I get to the point where now the pressure in the atria exceeds the pressure in the ventricle, the mitral valve opens, and we start that cardiac cycle all over again. Does that make sense? Let's go back to the factors that influence your stroke volume. How do those things affect your pressure loop, your pressure flow loop? Well, we said that increasing preload and we said increasing contractility increases my stroke volume. We also said that increasing my afterload decreases my stroke volume. And here we can see it on those pressure loops, volume loops. And you can see here's the normal example. So we didn't change any of the three factors that affect your stroke volume. That's going to be your baseline. Let me increase my preload. So now I'm increasing the volume of blood at the end of diastole. And remember, we talked about at this point here on the normal pressure is your end diastolic volume or your end diastolic pressure, right? So let me increase that preload and let me shift that over up and to the right. So now I have a larger volume in the ventricle at the end of diastole, but I also have a higher pressure in the ventricle because I was able to take on that additional volume. Now look at the work that occurs under this pressure volume loop. All of this work here is added to that cardiac cycle simply by increasing your preload. So increasing the volume of blood able to circulate out of the heart increases the stroke volume. Let's look down at the increased contractility. So now I'm not changing the preload, so I'm not changing the volume that's there. But now what I'm going to change is how strong that contraction is. So I'm going to increase my ejection fraction. So we said normal ejection fractions from 55 to 75%, right? But let's increase that contractility from 60% to 75%. So now 15% more blood is circulated out. How does that look? Well, if I am able to generate a more powerful squeeze, I'm able to keep that pressure high enough to keep that aortic valve open. Now you can see I, one, can generate a higher pressure, but I can also then maintain that pressure at a high enough level, even though the volume drops off. And now I'm adding all of this work to my stroke volume. Okay? So both increasing preload and increasing contractility increases my stroke volume. But let's look at increasing the afterload. We said that this has an inverse relationship with your stroke volume. So you have your stroke volume drops with increasing your afterload. And you can see if I have a higher pressure on the other side of the aortic valve, I have to generate a higher pressure just to open that valve and get blood circulating out of it. And then I have to maintain that much higher pressure in order to keep the flow of blood happening. But because of that higher afterload, now I'm having a premature closure of the aortic valve, and now I'm losing all of this stroke volume here. Because I had that premature closure of the aortic valve, because that afterload was too high and required me to have to maintain a higher pressure in order to maintain that open aortic valve. Okay. Does that make sense? But let's add some confusion to it, because you also have Frank Starling to think about. Frank Starling says as you increase preload, you're going to increase your stroke volume to a point. Okay? You can see on this curve It's increasing my stroke volume as I'm increasing my pressure or my volume. And then I get to this point, and now I start getting a drop off. And the reason for Frank Starling is the actin and the myosin fibers located in your sarcomeres, okay? You can kind of see in this little graphic here, but what happens is, think of this. You take your hands and you put your fingertips at your first joint, or the proximal, the PIP joint, and then you just kind of squeeze. You're gonna get some movement, right? Let's now go to the DIP joint. I'm gonna get a lot more squeeze with that, right? But now let me stretch out by increasing my preload. So now I'm having very little interaction. Maybe one or two of the actin myosin fibers are interacting with each other. Now I get a very uncoordinated, weak squeeze because I've stretched this thing out too far. Think of it as I take a rubber band and I stretch it out so it loses its elasticity. How strong is it going to be able to snap back if I've stretched it out too far? That's what happens with Frank Starling, and why, yes, increasing preload is a good thing and increases my stroke volume to a point. And this is a concept we really are going to delve into in block 3 when we start talking about heart failure, particularly heart failure with reduced ejection fraction. Okay. And then here's a pressure loop thing that shows you what increasing and decreasing your contractility will do. If I give something that increases contractility, you should expect to have a larger stroke volume. If I give you something that decreases your contractility, I'm going to see a reduction in my stroke volume. And you can see it on the graphic there. But that is the complex physiology of what's going on in the heart. And when we talk about any cardiac pathologies over the course of this instructional block, you're going to see these pathologies all come down to what is it doing to the stroke volume, what is it doing to the preload, and what is it doing to the afterload. And if I have a variation in any of those factors, it means there's going to be a functional impact related to that. Okay? So all that we're going to talk about this semester boils down to afterload, preload, stroke volume, contractility. Okay. And then, as I promised, here's our PANTS blueprint. Unfortunately, we don't have any red lines marking off because we didn't talk about a new topic yet. I promise you in lecture 4 we'll start marking things off. But the first 3 lectures are foundational review, and we're not going to mark anything off. So, do I have any questions? Okay. All right. Enjoy the 4-day. We'll see you all back on Tuesday, and good luck on home.
Thanks, man.